Welcome back. I'm Dr. Pete Davis. I'm a consultant in diabetes and endocrinology, and this is the third part of 5 on clinical endocrinology for third-year medical students, the adrenal gland and its disorders. So a few things you need to know about the adrenal glands to begin with. Well, their alternative name is the suprarenal glands. Sounds like it's a superhero, doesn't it? And that's because they sit on top of the kidneys. They're small, and they're not really all that easy to see. Sometimes they can be missed on scans. Because they get an awful lot of blood through, they can be a place where things like infective agents and cancer cells end up seeding, and they're said to be the fourth commonest place for metastatic disease. They have an interest in this oxymoron again, interest in embryology, and rather an ancient embryology as well. There are two components to the adrenal glands. There's the adrenal cortex on the outside, and a bit like a Malteser, it's got this lovely bit on the inside as well, the adrenal medulla. So the adrenal medulla, its embryology comes from the nervous system, and these cells produce catecholamines. But the cortex has a very different embryology, and if you were to look at it under the microscope, you see distinct layers: the zona glomerulosa, the zona fasciculata, and lastly on the inside the zona reticularis, and they give rise to these different types of hormones. So broadly two classes of hormones we need to consider when it comes to the adrenal glands. Two main classes, I should say. The glucocorticoids are the main class of hormones. The commonest one you'll be familiar with is cortisol, and cortisol is responsible for many aspects of glucose homeostasis, for healing during times of illness, for supporting blood pressure, and it's under direct control from ACTH from the pituitary. Mineralocorticoids, on the other hand, are responsible for fluid and salt balance. The principal one you'll be familiar with is aldosterone, and that's part of the renin-angiotensin-aldosterone system, RAS or RAAS as it is sometimes called. So we'll begin with hyperfunction, overfunctioning tumors of the adrenal gland. So this would be a special cause of Cushing's syndrome if it makes an excess of cortisol. Now that's not a typical cause for what we know as broadly Cushing's syndrome. Cushing's syndrome is predominantly this very specific form that we met in an earlier lecture, where ACTH production from the pituitary is driving a high level of cortisol from the adrenals. So you can think of it really as secondary hypercorticolism, secondary because it's occurring as an indirect consequence of the high level of ACTH. So that's by far and away the commonest reason, endogenous reason I should say, for people to have Cushing's syndrome. The commonest reason overall is actually people receive corticosteroid type of drugs, iatrogenic or extrinsic Cushing's syndrome. So after we've excluded pituitary dependent Cushing's, we've got this other collection of entities, of which adrenal adenoma is one, and adrenal carcinoma is another form that would come from the adrenal glands. There is this other special example which I've mentioned there called ectopic ACTH production. I'm not going to say too much about that right now. It does form one of the extensions that you can try. So what if we get the reverse? What if the adrenal glands stop working? Well, what this means for low levels of cortisol gets called Addisons disease, which is primary hypoadrenalism, absence of cortisol. So the effects that this has are shown on this slide: weak Patients feeling very tired, losing a tremendous amount of weight, often over prolonged periods of time. Some specific symptoms can accompany it, such as abdominal pain, unexplained abdominal pain, and low blood pressure. Low glucose is another possibility. Low sodium levels in the blood is another type of presentation that you can sometimes meet. And because of very high levels of ACTH, this leads to this characteristic pigmented appearance. You see that here on this lady's face, and you can see it in areas where there is rubbing. In this case, the teeth rub on the inside of the mouth, but you see it around sort of bra and panty lines as well, and in scars that people may have too. Well, Thomas Addison was the first to describe this condition, and in his day, the commonest reason to have adrenal glands that didn't work was because of infective destruction from tuberculosis, and it also be accompanying that calcification as well of the adrenal glands. But by far and away, the commonest reason we see today is one of a variety of organ-specific autoimmune diseases, and I've listed a few other ones on the bottom of the slide here that often go along with Addison's disease. For example, in patients that we meet with type 1 diabetes, when they get unexplained hypoglycemia, we sometimes need to exclude Addison's disease as a potential cause. We touched on the effect of the blood going through the adrenal gland, meaning that cancer cells can seed out, and it can be a site of metastasis. In clinical practice, I can't remember seeing a patient with hypoadrenalism that related to metastatic disease. I guess when things get that bad, the patient is probably close to terminal anyway. In some parts of the world, fungal infection can be a particular special cause of infection leading to hypoadrenalism. This is seen a lot in the USA, where systemic fungal infection is much more common than in the UK. Infarction of the adrenal glands through things like septicemia is seen sometimes. This used to be called the Waterhouse-Friderichsen syndrome. So as with any type of deficiency state, the answer is to replace what the person is lacking. And for some years we didn't really have a very physiological type of replacement for cortisol, and we used to use things which were a bit similar to it, and they'd have some crossover as having a component of glucocorticoid and another component of mineralocorticoid effect. Until the advent of hydrocortisone, probably about 20 years ago or so. And we now understand that the typical daily replacement for hydrocortisone is about 15 milligrams a day. When I was first qualified, we thought it was about double that, and we probably ended up over-treating people more than we should. There is a circadian rhythm we're trying to mimic. Cortisol is a wake-up hormone, so we give the majority first thing in the morning. Some patients are so sensitive they set an early alarm and take their first dose an hour or two before they actually start to rise in the morning. The afternoon dose, some people find if they take it earlier in the afternoon they actually sleep better late at night. But typically people would take it morning and evening. That would be the traditional way to do it, but be aware that many patients will have very, very good ideas about how this makes them feel, and will find their own way of making this work for them best. When it comes to replacing mineralocorticoid, that's very straightforward with fludrocortisone, just a small dose of that each day. So if you treat this comment at the bottom as a little bit rhetorical, the point I'd make from that is that unlike some hormonal systems, if you try measuring cortisol levels, you can't reliably use that to know whether people are on the right dose. You have to go much more on what you could consider ballpark figure, and very much on how people are feeling on their replacement dose. Listen to the patient. That's always king for me. So that's it in this third video of 5 about endocrinology for third-year medical students. Come back next time for the very exciting topic of gonadal disease and calcium metabolism. See you then.